Hi, and welcome to Module 4, Lecture 2 for Community Health Advocacy and Social Movements. Today we'll be talking about the history of mental health care in the U.S. health system, alternative approaches to mental health care, discussing mental health issues in high-risk communities, understanding the role of NIMH and APA. This is the National Institutes of Mental Health and the American Psychological Association, and understanding uses and limitations of psychological first aid. So your readings for the week are George Everly, the Psychological First Aid, looking at a few videos of people just speaking about mental health from their own perspective as patients, and looking at another video of a man who made a documentary called Crazy Wise, and it's just a kind of a look into what he was approaching with this documentary. It's not the full documentary, it's just a TED Talk. So I'd like to give the credit for much of the content in this presentation to your textbook, Nancy Niles, and JB Learning for Chapter 13. So please make sure to read the chapter. And so we'll begin with an introduction here about the kind of big picture of mental health. So behavioral health, another word for mental health, disorders will surpass physiological diseases as a major cause of disability worldwide by 2020, according to your textbook. Mental illness is the leading cause of disability already in the USA. In 2014, an estimated 44 million adults ages 18 years and older experienced a serious mental illness. Access to mental health services has been limited due to stigma, and that's a word that'll come up a lot in your lecture today. So if you are unfamiliar, it's societal discrimination. It's the stigma. You probably heard that in our video that we saw in week 1 with ACT UP, just the attitudes that people have towards conditions that are seen to be shameful or something like that. So there's a lot of stigma against mental illness, and it has been and it continues to be a major barrier to treatment, to seeking treatment for patients. So mental health advocacy, this is what this lecture is about today. There's a lot of just statistics and content in there, but keep in mind that everything that's mentioned in this lecture is for advocacy, for you to know more so that you can help patients dealing with mental health issues. So the concept of mental health advocacy has been developed to promote the human rights of persons with mental disorders and to reduce stigma and discrimination. It consists of various actions aimed at changing the major structural and attitudinal barriers to achieving positive mental health outcomes in populations. And that could be of patients, it could be of providers, it could be of service organizations, it could be changing the structural sort of paradigm of how we treat mental health, as well as the patients and sort of easing them through that stigma and moving away from it, even if it's there, how to help yourself regardless of what other people are saying or thinking. So the introduction, in your book, they say that over the last 3 centuries, the mental health system has consisted of a patchwork of services and is still fragmented. I would say I added this part, which includes a history of harsh and abusive practices towards patients with mental illness. And it describes that a little bit in your book, about lobotomies and removing parts of the brain of people with um, certain diagnoses of mental illness in the past, and moving away from cruel and unethical and discriminatory practices in treating mental illness, towards ethical and empowering and positive treatments. So mental health problems impact not only the individual, but often their immediate associates. I'm sure you've experienced this with a family or a friend or someone you know, um, that it's larger than the individual. It often extends to the community. Um, and depending on the severity, may also make an impact on the community, larger community. So suicide, um, gun violence, social disruption, and just when we feel the pain of that individual who's suffering as a community. So, as a result of the large spectrum of conditions that are labeled as mental illness, there are many forms of treatments and types of providers. The Diagnostic and Statistical Manual of Mental Disorders, or DSM, is a guide published by the American Psychiatric Association that explains the signs and symptoms that mark more than 300 types of mental health conditions. It has been used for decades to assess mental health conditions. However, the National Institute of Mental Health, the world's largest funding agency of mental health research, has refused to endorse the 2013 DSM and will no longer fund mental health research based on the DSM mental health categories. And from what I've heard of different providers, that's a positive step for NIMH, because the DSM is highly subjective as a tool. And our guest speaker, who will also be added to your lectures page on Canvas, talks a little bit about that. So the Mental Health Parity Act was passed in 1996 to ensure there was adequate coverage for mental health illnesses and that annual lifetime reimbursement limits on mental health services were similar to other medical benefits. This was really important because it's finally giving the right of accessible care in terms of cost to people with mental health or mental disabilities. So the Mental Health Parity and Addiction Equity Act of 2008 further supported mental health care by requiring insurance plans to offer mental health benefits and cost sharing similar to those of traditional medical benefits. Again, our guest speaker talks about this as well, that mental health practice and treatment is moving towards combining addiction with mental health care. So who provides mental health services? So in figure 13 of your book, they show the de facto mental health system. Basically, there's families, there's primary care providers, and then these two are clearly not skilled in providing comprehensive mental health, but families are often the first ones to take charge of a family member who has mental health. Sometimes they are the only providers for that person's whole life. Sometimes they're the ones who take them to the doctor and say, hey, I think my son or my daughter or my mom needs help. Primary care providers do the same thing in advocating for a patient. They may identify a problem during a routine checkup or during a checkup for a different issue, and and refer out to a specialist, or maybe try to treat the person depending on their personal comfort level. So psychiatrists are also medical doctors, but they can medications, whereas psychologists and social workers are also mental health providers and considered specialists, but do not prescribe medications. So, but they do therapy, they do counseling, they do other maybe comprehensive types of treatments that other healthcare workers don't do for mental health. So school counselors are also a big part of this mental health care system that your book didn't mention, and I put that in there because I know many school counselors, and they do a lot of work with sort of that first interface with mental health for young people in schools. Holistic counselors are also not mentioned in your book, but they're types of providers who are very diverse in their training, but trained specifically in counseling from different perspectives. There's traditional medicine providers, and we'll get into this more in a later slide, but thinking about the difference in the evidence base here, that these are very old sciences, thousands of years old, and they're basically the same as they were when they were sort of since the beginning of practice. So they haven't changed much. So the evidence base for these kinds of treatments, which might be meditation, acupuncture, sort of cultural healing practices, they've been around for thousands of years, and in that sense have the same legitimacy in observational science as our randomized control trials do today. In a different sense, they also have that legitimacy as mental health treatments that are culturally appropriate. So people who provide mental health services are specifically our social workers. Our guest speaker is a licensed social worker focused on mental health counseling. They generally have a bachelor's of social work or a master's of social work. Nurses and nurse practitioners may specialize in psychiatric care. National Alliance on Mental Illness, NAMI, and Mental Health America are non-governmental organizations that provide education, advocacy, support for patients with mental illness. And there's many organizations of that nature that provide support for mental health. So when we're talking about, I guess mainly just now in the last few minutes, we were talking about outpatient care. When we're talking about inpatient care, there's a law for committing a patient to an inpatient treatment center. Voluntary commitment occurs when people commit themselves willingly to receive care to an official institution that provides care. If a person voluntarily commits for a treatment, that person can leave on their free will. Involuntary commitment occurs when people are being forced to receive treatment or are committed to a facility against their wishes. Generally, they cannot leave without discharge approval from whoever has legal power of attorney over them. So now moving on to private and public funding. Medicare and Medicaid account for a large fraction of entities paying into mental health services in the United States, particularly for individuals with debilitating mental disabilities who often also cannot work. Medicaid is the single largest payer for state-financed mental health care. So I'll leave you with that thought until the next lecture, part 2 of the same lecture, I mean. So hopefully you'll check out your reading, chapter 3 of the book, and see you next time.